And good morning and happy Wednesday. Thank you all for joining onto the call for this month's edition of Brightview Refresh. My name is Brian Jackson from the Learning and Development team, and I would like to welcome you. Just to give you a little bit of background of the Brightview Refresh once again, this is going to be a monthly kind of training chat in which we take one of our esteemed colleagues or esteemed guests from the Brightview team and have them come on and talk about a specific topic. We have about 6 to 8 prepared questions that we will utilize, and then also give a chance for those of you that have jumped on the call via Teams to use the chat function and ask questions as well. This will go from 9 to 9:30, and it will be recorded. So if you have to jump out, or if one of your teammates were unable to join today, we will be able to get you out that video for you to be able to watch that as well. I want to introduce our guest of this month is Dr. Kang. Dr. Kang, welcome to Brightview and welcome to Brightview Refresh. How are you doing today?
Thanks for having me, Brian. Doing well.
If you can talk a little bit about yourself, how did you got to Brightview and what's your position title here and kind of what do you do here?
Sure. I'm transitioning title a little bit right now. I've been the chief clinical officer here at Brightview for about 3 years. I'm a psychologist by training, and my title is going to change to chief quality officer here in the next couple of months or next couple of weeks, whatever. But I'm a therapist by background, so I came to Brightview 3 years ago after being at Mercy Health. It's a large health system in Cincinnati, Ohio, et cetera. So I worked in the inpatient space, worked in the emergency room, just saw like we didn't do a great job for people with substance use disorder in any treatment setting.
Yeah.
And frankly, as related to our conversation today, had a lot of people that we sent out for addiction treatment who then came back to the hospital pretty quickly thereafter because they were like, not accepted, they got kicked out, whatever it might be, and they had like nowhere to go. So it was a little bit of an impasse. And at the same time, our local community and then nationally, we're facing a mortality crisis. So a lot of that, like, piqued my curiosity of like, what are we doing here? It doesn't seem to be working. What are the protocols that we're using from a treatment standpoint, but just like what's our philosophy as it pertains to treating people with substance use disorder, and just found like a lot of variation and a lot of pretty bad practices, to be honest with you, just like treating people unkindly and things like that. So came to Brightview because it's different.
Yes.
And we're meant to be disruptors in this industry and help people in a way that, not enough people are doing.
Good. Well, thanks again for joining us today on Brightview Refresh. Today, Dr. Kane and I will be talking about harm reduction. We're going to go a little deeper into the understanding of harm reduction and kind of talk about how does it work, what does it look like, what does it look like in our work, and what are maybe some of the misconceptions that we have. So let's go ahead and jump right into it. Dr. Kane, if you can you talk to us about what does harm reduction mean?
Yeah, that's a good question. I think I usually consider it in two main buckets. So, what does harm reduction look like out in the community? And then what does harm reduction look like inside of the four walls of a Brightview?
Yeah.
And how do we make use of that concept as part of our treatment delivery within our treatment teams? So most people think of it out in the community. When you think harm reduction, you look at like, the White House's plan from the Office of National Drug Control Policy, or, what's generally in the media around harm reduction. People think of syringe exchange programs or the distribution of fentanyl test strips.
Yep.
I read a study this morning actually about like, feasibility of distributing fentanyl test strips from an emergency room setting as an example. And then of course, Narcan distribution. Narcan is the intranasal version, it's brand name version of naloxone, the opioid overdose reversal agent. So people think of, how do we get those kinds of things out into the community? Just to like break the term apart, harm reduction, it's about reducing harm, reducing secondary harm specifically. So in the case of having someone with substance use disorder, let's say that they're not engaging in treatment or their SUD is not being stabilized or something like that. Because, not everyone's ready for treatment or it's just not available in every community, frankly. We can reduce the secondary harms of having that substance use disorder through some of these other interventions, right? So if we offer someone a comprehensive syringe exchange program or a bloodborne pathogen program, sometimes they're called, you have the opportunity to prevent secondary infections, right? So someone is coming in, they're providing or they're exchanging used syringes for new ones. That's an opportunity then to make sure that they're using new, fresh supplies. Yes, they're still engaging in intravenous drug use, right? So that an underlying problem is not necessarily being addressed, but they're prevented from acquiring hepatitis C or HIV. We did some work here in Cincinnati with Hamilton County Public Health on this. We found that at the time, if you prevented one case of hepatitis, just as an example, you could fund a syringe exchange program for a year.
Wow.
In the county.
Yeah.
Now it's more like 4 or 5 because the cost of the medication has come down, which is a good thing. But if you just find a few people and prevent that infection, you can save a lot of money to the local community and obviously prevent a lot of suffering for that person. Narcan is somewhat similar, right? A secondary harm of having a substance use disorder like opioid use disorder and engaging in intravenous drug use, using what you think is heroin, but it's actually fentanyl.
Yeah.
A secondary harm of that is dying.
Yeah.
And overdose mortality is something that you can prevent through that harm reduction effort. I think a lot of like lay people, probably outside of Brightview generally, but maybe some folks on our team as well, don't necessarily understand that it's all of these things are more than just a transaction.
Mhm.
So some people think, hey, you're facilitating drug use, you're giving people syringes. They'll ask public health that kind of question, right? Or in the case of the emergency room that I'm referencing, they may say, aren't you facilitating people to use drugs if you're giving them fentanyl test strips and this kind of thing? Well, if you look at it as just a transaction, I can see how you might have that misinterpretation, but it's more than a transaction,
Yeah.
right? If we bring someone in and we treat them with kindness, then we might actually convert them to treatment. And that's what CDC data bears out from
Right.
multiple years of research, right? The people who participate in a syringe exchange program are 3 times as likely to seek out treatment like what we provide and stay in treatment as well, actually.
Good. Good. Thank you for that.
Inside of Brightview, probably more relevant to our team, it's about our harm reductionist, non-punitive clinical philosophy, right? The idea that we want to work with people in the long term and have a long-term path to recovery in mind, right? A lot of times when people come to us, I mean, our team can certainly attest to, they come in very sick. And so it's unlikely that we're going to have an overnight magical solution. Although sometimes someone comes in 7 days and you're like, we have to take another picture of this person because they look so different. The transformation starts so quickly. But we're not necessarily curing the underlying disease or stabilizing it. Cure is probably a bad word, but like stabilizing or getting the underlying disease into remission doesn't happen overnight. And so we want to work with the person in the long-term mindset. We understand that there's going to be perhaps setbacks and certainly challenges that people experience. And those challenges are different in the first week versus the first 90 days versus the later in the first year of treatment. And so we need to be adaptive and creative with how we work with folks. And that's really no different than when we're addressing any other chronic disease in healthcare, right? I used to work in primary care as well. And so when we had someone with diabetes come in, they're trying to change their diet. They're trying to change their lifestyle, like exercise and things like that. Well, they're still going to family functions and the food that's cooked is still the same as it always was before. And the other people in their system aren't necessarily changing. And it's hard to get up at 5 o'clock in the morning and exercise every day or whatever it is, right? Or who wants to do that at 10 o'clock at night? I certainly don't. I know a few people who do, but that's a tough thing. And so if someone may be motivated to get started and it's important to continue offering motivational enhancement and removal of barriers so that they can achieve a level of dedication in pursuit of their goals.
Definitely. Thank you about that. So you kind of went into it, but can we, what are some of the benefits of Brightview using the harm reduction approach in the method with the spaces? So like, what are some of the things that we can see? What are some of the benefits that we see as well?
We actually help people. I mean, that's the underlying thing, right? Because if we think about how other treatment programs operate, it's like, hey, if you didn't do this thing, then you're not welcome here. Or 3 strikes and you're out, or you've been here so many times, now you're on some kind of blacklist, you can't be admitted again, or that kind of thing. Well, if that's the case, then many times there isn't another opportunity or another treatment provider that they can go to.
Right.
And so how does that benefit someone, right? So for us to think about applying a harm reductionist, non-punitive mindset is really just about common sense, right? Like if the person goes with no treatment, that is by definition worse than having some treatment.
Right.
And certainly using the treatment model that we offer with a combination of medical, nursing, clinical services, and again, compassion, dignity, respect, doses of all of those interventions, if we think of it that way, go a long way. In the absence of those things, that's what someone would experience if we were to kick them out or put them on some kind of punishment or something like that. And ultimately, when we think of behavioral health, when we think of substance use disorder in particular, a lot of our patients have experienced a fair bit of trauma in their past as well, right? So there's several ramifications of having had traumatic experiences. One potential is developing a substance use disorder, among many other risk factors that can produce that. But like, for patients to know that we are going to be treating them with grace and with dignity and with respect, that alone can motivate them towards their goals.
Absolutely. Yeah.
And so, ultimately the answer is us applying harm reduction gives us a greater chance of helping people.
Yeah.
And being effective in what we're trying to do.
Definitely. Thank you for that. So, I think that we've kind of talked about harm reduction from a larger space. Like, let's try to bring it in. So, we obviously have some seasoned individuals that are on the call and probably some people new to Brightview. So can you talk about like, what does harm reduction look like in our work?
Yeah. I'll preface this answer by saying it's a lot easier said than done, I think, right? For a few different reasons. So one reason is many people who come to Brightview have practiced in the other way. And so if that's what you've been taught, that's what you know. And what's interesting is a lot of people come to Brightview because they know that we practice in this different way, right? I do new hire orientation every week. I'll tell everybody this afternoon who's new to the organization. Yes, if you came here because you want to practice in a harm reductionist way, I'm proud to be able to tell you, we don't fire patients from treatment for struggling with the condition for which they're seeking our help, right? But it's a lot easier said than done if you've been trained a different way.
Yeah.
And so, for anyone who's listening, whether you're new, been here a while, whatever it is, like if you have questions about how to practice in that way, there's a specific case, specific patient. That's what supervision is for. That's what treatment team is for. That's what any of us are for in terms of leadership, because many times the creative solutions that we have to find with our patients are not easy to come by, right? And we have to rely on the power of the treatment team to develop them. And so, I think when we apply a harm reductionist approach in our practice, it's about keeping the patient safe and thinking about relative progress. So for one person making some progress or achieving a period of stability where they're not getting worse could be a monumental achievement. Like they haven't used in 7 days or something like that. It is a huge accomplishment for one person. Whereas for another person, it might be 3 days, or it might be using less than they used yesterday. So the whole concept of safety has to undergird what we do as well. But ultimately, if we rely on our collective experience and we ensure that we're training people towards harm reduction, right? Because folks come to us, they want to practice in this disruptive way, in this unique kind of way. We're responsible as clinical and medical leaders, as well across disciplines, really. Like we have to be responsible to train folks on how to do it, so that if they do have some antiquated practices that they've been trained in, they can avoid defaulting back to those. The other reason why harm reduction is easier said than done is just because we care about our patients, right? And so substance use disorder is an intractable illness many times. It is very difficult to treat. And so when we are invested in our patients and we care about how they're doing, it is tough work, right? And it's easy to take it home with you and think about, like, when a patient relapses or they're struggling or they overdose or whatever it might be. And so again, that's where it's so important for us to have routine supervision, for us to care about each other as well, because we get invested in how our patients are doing. I always like to say, like, the people who are taking care of people who use drugs are people too, right? They're all people, right? And so we get invested in our patients, we get invested in how they're doing, and we take it personally when they don't do well. And on some level, that's a very good thing, but it also creates a risk that we can get frustrated. Then we can default to, like, well, they're not serious, they shouldn't be here. Can we discharge them or something like that? That's where the rest of us have to wrap around that person and be like, well, here's a better way, or here's a different solution that we can think of.
Thank you for talking about that. So I've done some research on harm reduction and kind of read some articles, and you shared with me the White House briefing as well, and I read a good portion of that. And I think anytime when you see something that has a positive space, you also see some critics or something that criticizes it as well. So one of the common themes is that harm reduction like removes the punitive motivation for individuals to kind of walk through and recover from substance use as well. So can you talk through some of the criticisms and why is it important for us to understand the benefits of harm reduction?
Yeah, it's a great question. I think many critics of a non-punitive approach, like what we apply, they feel like there isn't a tool that they have then to motivate the patient, right? So if we're not, if we're not threatening them, or if we're not withholding medication, or if we're not, you know, showing them a behavior contract that says if you don't do A, B, and C, then we're going to do X, Y, and Z, right? People feel like if we're not using those kinds of tools, then we're disarmed.
Mm.
What I would say is that that's false because we have other tools, first of all, but we probably need to develop better ones. If that's all we've got,
Right.
we're a little bit behind,
Yeah.
right, as an industry. And so some of the other tools we already have, again, compassion, dignity, respect, the clinical team would call it the Therapeutic Alliance, right? The idea that we don't have an adversarial relationship with our patients, that we have one that is collaborative in nature, that is transparent, that is, meant to be communicative and things like that. And so, when we think about therapeutic alliance, collaboration, dignity, respect, compassion, ultimately, again, all of that indexes on safety. If we believe that in order to make progress, we have to have a healthy relationship with the patient. They have to trust us as individuals, as a team, as an institution.
Yeah.
They're more likely to come back to us when they're struggling, right? I think everyone's had the experience on some level of like, hey, you as a teenager, you did something wrong. Like, do you want to call your parents or do you want them to know or not? And people have different experiences of that, right?
Yeah.
For our patients, we want to be the safe haven where when they're struggling, when there are issues, when there are challenges, they come to us first. And every center has patients who come in multiple times a week, some every day, unscheduled. Some people just want to sit in the waiting room because they feel a sense of safety. I don't need anything from you guys today, just needed to feel the energy of the place. And I'm going to come back tomorrow for my appointment or whatever it is, right? Of course, the team is available to see them and do anything else that they might need. But those are the things that we want to pursue and create tools out of that kind of framework, right? So think about every visit counts. That isn't about requiring a patient to do a certain combination of visits in order to advance to the next level or in order to stay in treatment at all.
Right.
That's about educating people that says, hey, thousands and thousands of people like you came here to us. They did this or more, and they achieved their goals. Goals very similar to the ones that you have. That means your goals are very possible to achieve if you did something like this. So let's talk about motivation. Let's talk about barrier removal. Let's see how we get you either to this level of engagement or more, or as close to it as we possibly can. It's not that the patient says, well, I can't do all of what every visit counts is saying, so I need to leave or something.
Right.
That's not the idea, right? It's about education, transparency, and again, problem solving, right? To ultimately keep the patient as safe as possible and work with them in the long term. Ultimately, when you look at the addiction treatment literature, substance use disorder treatment literature specifically, duration in treatment is the undergirding metric. So retention in treatment, how long is someone in treatment, ultimately underpins every other good outcome that we're seeking.
So it's really like a lot of things that you're talking about is really the harm reduction. It's like almost seeing the individual as a person and really like just kind of navigating into that space and like creating a sense of trust and a sense of care. Just like really just seeing that person for a lot of the things that they're going through and kind of what their life has kind of gotten to that point before they kind of walk through the door.
Yeah, we treat addiction like a disease and we treat people like people.
Yeah. So as we're working at Brightview to help patients on their road to recovery, what are some things that we should consider when approaching our work through a harm reduction lens?
Yeah, again, just remembering that it's easier said than done. That those of us who are delivering care are people as well. That's whether you're a direct care provider or you're supporting the people who are taking care of patients, behind the door. As many people have heard me say, it's easier said than done. So seek consultation, seek supervision. We've been very intentional about building our teams in such a way that hopefully folks aren't feeling like they're practicing on an island. Regardless of which discipline we're talking about, operations team, clinical medical nursing, those who are seeing the patients most often. And that includes whether it's from a telehealth standpoint or again, talking to a patient about their financial status and their, like if you're feeling like you're working on an island, that is not what we want. So reach out and seek consultation and collaboration because all of this is so much easier said than done. Ultimately, keep safety in mind, right? The longer that we keep the patient engaged in treatment, the more opportunities that we have to help them in the long term. And think of it this way, like we have examples every day. We have a patient who's coming in for opioid use disorder treatment. We're providing them with medication for their opioid use disorder. That's stabilizing. They're engaged in counseling, group, individual, whatever it might be. They're seeing a case manager, but they're continuing to use methamphetamine every day. This happens every day, right? Across this country, not just within like the Brightview patient population. This is not everybody, but everyone can think of patient who is struggling in this way. If we were to remove that patient from treatment, would they be safer tomorrow? By definition, they would still be using methamphetamine tomorrow.
Yeah.
Now, if we removed them from treatment, they might also be injecting heroin, which by the way, probably isn't heroin, it's probably fentanyl. So by definition, they're significantly less safe tomorrow if we discharge them or something like that. So seek consultation, be creative, understand that it's easier said than done. And also don't let the perfect be the enemy of the good. Right? Like if we're working with our patients and have a creative solution on how to take best care of them, try it.
Yeah.
Right? Let's see what works. If they're willing to try it, if they're excited by either an intervention or some other service to engage in as part of a coordinated care effort, that's excellent, right? And sometimes I think people are surprised by what we offer inside of Brightview even as well, right?
Mhm.
So even inside the four walls of a Brightview or through a telehealth intervention, whether it's psychiatry or case management or peer support services, sometimes patients are like, "Oh, I didn't know you guys even had that here."
Right. Yeah.
And so there's so much that we can do, but sometimes we don't always think of it, and we may not have the experience, or we just might be frustrated or challenged by the case that's in front of us or the person that's in front of us, and so seek supervision, seek consultation. We're all here to help each other.
Yeah. So really like the harm reduction approach that we're hearing at Brightview is that, like you said, it's like not on the island. Like we have to really learn how to lean on each other and kind of like navigate through each other, work as a team to kind of go through that process as well.
Yeah, if someone else had already figured all of this out, we wouldn't be in like this collective mess that we're in as a society, right? Like we have a societal addiction crisis that we are facing. And I know sometimes the numbers make us all kind of glaze over because you hear it so often and everything like that. But uh, the way that we get out of this is not like a known thing, right? It's not like there's a path that we're walking that someone else has already blazed in a lot of ways. Like there's great treatment innovations and solutions and some great ideas have been out there for 50 years. Many people have heard me say that as well. That's also true. But if someone tells you they already know exactly what to do at the population level and at the individual level, it's like, yeah, they might not. They might just be missing something. This is pretty complex stuff. As I think everyone at Brightview can attest to.
Well, Dr. Ken, mind, there are some questions that are here in the chat that I wanted to kind of ask for you as well. So, Noel asks, like, how would you approach a patient that reports that either he or she cannot come into the clinic more than once a month due to a work schedule?
Yeah. So again, with a patient like that, that is going to be a realistic thing, right? So we've had patients who have said to us something along those lines in a variety of ways, right? So sometimes there's a patient who comes to us, let's say every other Friday, and there's actually a patient at our Centerville, Ohio location who I'm referencing here. So she was coming in every other Friday and was at Brightview for about 4 hours every other Friday afternoon. And her boss was like, "Hey, I don't know where you're going, but like you can't be gone for that long every other week." And she was able to come in every other week, but it wasn't for 4 hours, right? So we just had to have a little bit more organization and efficiency to get all of her visits done. I think the attestation was like, you guys should be able to have me see the medical provider, see my counselor, and participate in the OTP and lab service in less than 90 minutes. It's like, yeah, that's probably true. We probably should be able to do all of that in less than 90 minutes. So for the patient who can only come in once a month, that could be a very pragmatic thing. It could be distance, it could be the transportation, or it could be the work schedule. There's so many, real factors that people are oftentimes dealing with. And so what we don't want to do is be a risk factor for that patient, right? And so we don't want to be like, well, too bad you got to be here every week in order to stay a patient at Brightview. And instead, let's talk about some other opportunities to engage that patient, whether it's like telehealth services, some kind of alternating schedule. If we think that the patient needs to see us more often, let's utilize some of our other ways to connect. The visits can be briefer, the visits can be more efficient. There's a lot of ways to achieve the ideal treatment dose to ensure that the patient is stable and they're receiving the benefit of everything that we think that they need from a medical necessity and treatment plan standpoint.
Thank you. The next question that I wanted to jump into is Christina asks, can you tell us about a time that a patient was diverting their medication and how was that handled from like a harm reduction standpoint?
Yeah. So that that can happen, and we have a requirement to monitor the patient's access to medication and diversion and that kind of thing. So there's a legal risk to that and that kind of thing. So this happens sometimes in a few different ways. So one is the patient diverting their medication, and the other is patient accessing someone else's medication. And so there's someone who's diverting it and the other person is accessing it. Sometimes a patient is diverting medication to sell it for financial gain or whatever it might be, right? And so I think the first thing to do is be transparent and clear with it. Again, we don't want to be unnecessarily confrontational or like intimidating to a patient. It's the same way with our confirmation lab testing. There really isn't a need to be adversarial with any of these kinds of things, right? So if a medication compliance review or pill count, or again, confirmatory lab testing is telling us, hey, something's not right here. Your medication is missing, or someone else told me that, you were selling it to them in the parking lot and we have it on, some kind of video or, whatever it might be. Or again, your urine confirmation 99.9% is telling us that this other thing is in your system that's not supposed to be. It's not prescribed, right? Instead of using those as opportunities to argue with the patient, we should transparently share what we have found or what we believe to be the case, and seek to understand like what's driving that behavior. So there was a patient at Georgetown, for example, who was acquiring someone else's medication, and it's because we were underdosing them, right? So the patient has opioid use disorder. We were providing them with the buprenorphine product. They were receiving 12 milligrams, still symptomatic. They were buying 4 from someone else who was probably well maintained. And so that patient who was diverting it probably didn't need this is Georgetown, Ohio, by the way. It was like 17
I was like, we
Georgetown.
have to figure.
But the patient who was diverting it probably didn't need as much as they had, or there was a financial or economic situation that they're in. So let's work on that. Like, is there a job? Is there assistance? Are there other things that they can have their daily needs met? And for the patient who was buying the additional 4 milligrams, let's not view that as, oh, you're purchasing illicitly or something like that. It's like, hey, we're underdosing, you're still symptomatic. If we increase you to 16 milligrams, then maybe you'll be more stable, right? And so the treatment team wrapped around both of those patients to be able to understand what's going on, seek to understand what's driving the behavior, as opposed to having a knee-jerk reaction to say, well, you're not serious about treatment, so come back when you are, or something. Or one strike is on the board, right?
Yeah, definitely. Thank you. I want to be conscious of time and realizing that it's 9:32. I know that we have a couple of questions in the chat that I haven't gotten to. I will make sure that I share these questions with Dr. Kang and get the answers either via chat or in another format to get out. We understand that the harm reduction approach here at Brightview is one that a lot of people want to understand and a lot of people know and kind of want to talk about as well. But I do want to be conscious of time and realizing that we're at 9:32 as well. And I'm pretty sure that Dr. Kang had other things to go to as well. But again, I would like to thank everyone for attending Brightview Refresh, just to kind of give you a backside of what's going to happen later. This video has been recorded and it will go out once I get it all edited and everything like that is great. It will go out to the mass. So if you want to share it with one of your teammates that was not able to join today, or if you just want to go back and watch again, you're able to do that as well. I will also be providing some resources that Dr. Kang gave to me in regards to a blog that was written by Brightview, as well as the White House briefing there if you want to read that. I will tell you all, and Dr. King told me when he sent it to me, it's about over 50 pages, but it is, I mean, it's very informative if you really wanted to have a really good understanding of harm reduction, not only necessarily from a Brightview perspective, but also from a larger national perspective as well. But again, I just wanted to thank you all for joining us here on Brightview Refresh. Dr. King, I want to thank you for taking your time out of your Wednesday morning to join us as well. And if you have any questions or anything like that, please let me know. Have a great day.
Thanks, Brian. And for those who are watching, Chanel Wright is here as well. So shout out to Chanel and to Brian. I appreciate the opportunity to join you guys. Have a great day, everyone.
Thank you.